A very warm good evening to all present here today. We are having a live academic session on diabetes with eminent speaker Dr. N. Shubhapriya, Senior Consultant Diabetologist from Sri Narayani Hospital and Research Center. Today, we will be discussing in detail about inherited diseases that affect diabetic patients in association with IMA Medical Students Network, Jubilee Units, and Amala Institute of Medical Science and Jona Med. Over to Dr. Shivpriya. You can start your academic class now. Thank you.
Yeah, at the outset, I would like to thank each and everyone. Good evening to all. And I'm Dr. Shubhapriya from Sri Narayani Hospital and Research Center. And I would like to thank the organizers and IMA medical students and the Amla Institute of Medical Science and our director of Sri Narayani Hospital and Research Center for giving me this opportunity. So today we are going to discuss regarding the inherited diseases that affect the diabetic patients. So before going to the topic, let us first know the basics of diabetes, like definitions and the types. So now we'll start with the definition. So as we know, diabetic mellitus comprises a group of common metabolic disorders that share the phenotype of hyperglycemia. And there are just a metabolic disease in which the body's inability to produce any enough insulin causes elevated levels of glucose in the blood. So there are several distinct types of diabetes exist and are caused by a complex interaction of genetics, environmental factors, and lifestyle choices. So depending on the etiology of diabetes, factors contributing to hyperglycemia may include reduced insulin secretion, decreased glucose utilization, and there will be increased glucose production. So the metabolic dysregulation associated with diabetic causes secondary pathophysiologic changes in multiple organ systems that impose tremendous burden on individuals with diabetes and healthcare professions. So here, in US, diabetic mellitus is the leading cause of end-stage renal diseases and for non-traumatic lower extremity amputations and also for adult blindness. With increasing incidence worldwide, diabetes will be a leading cause of morbidity and mortality for the foreseeable in futures. So next, coming to the types of diabetes. So coming to the types, that is a classification of diabetes mellitus. This is on the basis of the pathogenic process that leads to hyperglycemia, and as opposed to the earlier criteria such as age of onset or type of therapy. So there are two broad categories of diabetes mellitus and designated as type 1 diabetes and type 2 diabetes. So coming to type 1 diabetes, a type 1A diabetes results from autoimmune beta cell destruction, which leads to insulin deficiency. The individuals with type 1B diabetes lack immunologic markers and they are indicative of an autoimmune destructive process of the beta cells where it is secreted in the pancreas. So however, they develop insulin deficiency by unknown mechanism and are more prone for ketosis. So relatively, few patients with type 1 diabetes are in the type 1B idiopathic category. So many of these individuals are either Africans, Americans, or Asians in heritage. And coming to type 2 diabetes, it is a heterogeneous group of disorders characterized by variable degrees of insulin resistance, impaired insulin secretion, and increased glucose production. And this distinct genetic and metabolic defects in insulin action and therefore give rise to the common phenotype of hypoglycemia in type 2 diabetes mellitus. The type 2 diabetes is preceded by a period of abnormal glucose homeostasis. So this classified type 2 diabetes, again it is of IFG, that is impaired fasting glucose or impaired glucose tolerance of. And the main two features of the current classifications of diabetes diverge from the previous classifications. First, the term uh, insulin-dependent diabetes mellitus and non-insulin diabetes mellitus or absolute. Since many individuals with type 2 diabetes eventually require insulin treatment for control of their glycemia. The use of the term non-insulin dependent diabetes mellitus generated a considerable confusion in them. So coming to the second differences is that age is not a criteria in the classification of the system. So also type 1 diabetes most commonly develops before the age of 30 and autosomal immune beta cell destructive process can develop at any age group. So it is estimated that between 5 to 10% of individuals who develop diabetes after age of 30 have type 1A diabetes. Likewise, type 2 diabetes are more typically developed with increasing in age, but it also occurs in children, particularly in obese adolescents. So next coming to the specific type of diabetes. So in specific, another group of specific type, the first one is the genetic defects of the beta cell functions. That is, we say it as MODI, that is maturity onset of diabetes in young. And it got 5 variants, that is MODI 1, 2, 3, 4, and 5. So we are going to discuss this genetic defects in insulin action in later slides. So next coming to the pancreatic diabetes. So the diabetes can result from pancreatic exocrine disease when majority of pancreatic islets are destroyed. So more than 80% of the pancreas, when they are destroyed, it leads to exocrine pancreatic diabetes. Example, pancreatitis, pancreatectomy, cystic fibrosis, neoplasia, fibrocalculus pancreatopathy. And next coming to endocrinopathies. These hormones that antagonize the action of insulin can lead to diabetes. Thus, this diabetes often a feature of endocrinopathy. Example, acromegaly and Cushing's disease. And next variety is of drug-induced or chemical-induced diabetes. And next is infections that is which have been implicable on the pancreatic islet destructions, that is the beta cell destructions. So most commonly affected viral is the congenital rubella, and it is the greatest in increased risk of diabetes mellitus. And next coming to the uncommon forms is the immune mediated diabetes, and the next one is genetic syndromes associated with diabetes, like example like Down syndrome, Klinefelter syndromes, etc. So next coming to this other types of etiology that diabetes. This etiology for the diabetes include specific genetic types defects in insulin secretions or action. That is, metabolic abnormalities that impact the insulin secretions and mitochondrial abnormalities and a host of conditions that impair glucose tolerance. And this MODI, that is maturity onset of diabetes of the young, is a subtype of diabetes characterized by autosomal dominant inheritance. Early onset of hyperglycemia and there will be an impaired insulin secretion. So here, the mutations in the insulin receptors cause a group of rare disorders characterized by severe insulin resistance. So number 4 is the gestational diabetes, that is we call it as GDM. Here there will be a development of glucose tolerance during pregnancy. So here, and the next one is the pre-diabetes. Here are the ranges as we discussed. It is a pre-diabetes, impaired fasting glucose or impaired glucose tolerance, and the diabetes mellitus, like what we discussed, like insulin dependent one and non-insulin dependent. That is the type 1 is insulin dependent one, and type 2 is the non-insulin dependent. So coming to type 1 diabetes, it is also known as a juvenile diabetes, and it is insulin dependent diabetes, and it is usually diagnosed in children and young adults. Here, the body's own immune system destroys the insulin producing cells of the pancreas, that is the beta cells which produce the insulin. So 5% of the people are diagnosed to have this type of diabetes, that is type 1 diabetes. So here the body does not produce insulin and it is not preventable, or it doesn't have no primary interventions. So what is the cause? That is, as earlier we discussed, here the predisposition to diabetes, that is the genetics and any other something like any viral infections, etc. That is, these are the triggers for the diabetes. As already we discussed, the type 1A diabetes and type 1B diabetes. So next, coming to type 2 diabetes. Here the most common form of diabetes, that is about 90% of the cases, and it is also known as non-insulin dependent diabetes mellitus. And these are also called as adult in onset, and here the body produces insulin but does not use it properly. Here the glucose does not move into the cell, but it just go up, piling up in the bloodstream. That is, the blood got the glucose in the glucose is not utilization because the insulin cells, it is of inactivity due to insulin due to the insulin resistance. And here the body cannot use the insulin properly, and it can develop at any age, and most cases can be prevented in type 2 diabetes. So next, coming to genetic defects of the beta cell function, that is as earlier we discussed, that is MODY 1 and 2, 3, 4, 5, 6. Here that is hepatocellular nuclear transcription factors. So again, genetic defects in insulin action, that is type A insulin resistance, leprogenism, Rabson-Van syndrome, and lipodystrophy syndrome. So again, here genetic syndrome associated with diabetes, as earlier we said, that is Down syndrome, that is trisomy 1, Klinefelter syndrome, that is double XY syndrome. It is a genetic condition in which a male is born with an X chromosome, and Wolfram syndrome, Turner syndrome, Huntington's chorea, etc. So coming to gestational diabetes mellitus, that is GDM. So in GDM, we have the glucose tolerance may develop during the pregnancy. So having diabetes during pregnancy is known as gestational diabetes mellitus. So there will be a glucose intolerance. So here what happens is insulin resistance is related to the metabolic changes of late pregnancy, and it increases the insulin requirements and may lead to impaired glucose tolerance. So here the individuals will be having a family history of diabetes or maybe overweight prior to pregnancy, and this gestational diabetes will put you at a risk of type 2 diabetes in future. And here, this GDM occurs in approximately 4% of pregnancies in US. The most common road to normal glucose tolerance postpartum, but have a substantial risk that is around 30 to 60% of developing diabetes later in their life, that is in future. So like 18 out of every 100 pregnant females will develop GDM, and there are chances to continue the around 30 to 60% in future they may develop into type 2 diabetes. So what happens in this gestational diabetes, that is to the baby, due to the diabetes, like it will due to a large baby, that is we say it is a big baby, due to high blood glucose level in mother, it brings extra glucose to the baby and it causes the baby to give an extra weight. So next, coming to pre-diabetes. So pre-diabetes, it is a condition in which blood sugar is high and but not enough to meet the criteria of type 2 diabetes. So it is known as the impact glucose tolerance. So without interventions likely to become type 2 diabetes within 10 years, or nowadays it is within even 5 years also. So how this pre-diabetes, that is out of 86 million people, that is more than one out of three adults have been diagnosed as pre-diabetes. So around in the world, 86 million of people are suffering from this pre-diabetes. So 9 out of 10 do not have the pre-diabetes. How do you come out of this? That is 15 to 30% of the people with pre-diabetes will develop type 2 diabetes within short period, that is within 5 periods. So what will happen here is, without weight loss and moderate physical activity, we have to prevent it. So in the prevention program, so for the first thing what we are going to give the importance is lifestyle intervention, that is we have to increase the physical activity. So we got two groups, that is lifestyle intervention group and versus a medicated group, that is using the biguanide group of drug, that is metformin, and a placebo groups. So in this program, a subject of 3,243 participants have been used and with an overweight, and they had pre-diabetes. So what happened, the net result of this is the lifestyle intervention individuals have reduced diabetes by 58%, whereas 31% have been of diabetes have been reduced with the usage of metformin. So this is effective in both sexes, and the age group was around 25 to 44 years and BMI was around 30 plus. So overall what we got is this, like this type 2 diabetes can be prevented or delayed with activity and diet by increasing the physical activity and by lifestyle modifications and with a good diet counseling. So what are the symptoms of diabetes? So common symptoms of diabetes which include is excessive thirst and appetite and increased urination, and sometimes the patients very often will be having it, they will be passing with every hour, and there will be an unusual sudden weight loss. Some patients will go for weight gain also, and fatigue and nausea and perhaps vomiting and pain abdomen in type 1 diabetes, and there will be a blurred vision, and females very commonly, frequently, they come across vaginal infections, and men and women with yeast infections and dry mouth and slow healing sores and cuts, that is wound healing will be very delayed, and skin itching will be there, especially in the groin or vaginal area. So in scientifically we say it as polyuria, polydipsia, polyphagia. So now coming to the insulin. What is the role of insulin? What is insulin? So this insulin, it is produced in the beta cells of pancreatic islets. So initially, this insulin, this is the structure of the insulin, and this insulin is initially synthesized as a single chain. That is, it contains 86 amino acid precursor polypeptide, and it is a pre-pro-insulin. So subsequently, what happens here is this proteolytic processing removes the amino terminal signal peptide, giving rise to pro-insulin. So this pro-insulin is structurally related to insulin-like growth factors 1 and 2, which bind weakly to the insulin receptors. So after this binding, there will be a cleavage. So this cleavage of the internal 31 residual fragment from pro-insulin generates C-peptide and amino acids of insulin. So this insulin contains 51 amino acids. So it contains now A chain and the B chain. So this A chain comprises of 21 amino acids and B chain comprises of 30 amino acids. So here what happens next is the matured insulin molecule and the C-peptide are stored together, and they are and co-secreted from secretory granules in the beta cells. So this is a large number of islet cells as described, and here the pancreas put the insulin into the bloodstream, and insulin travels through the body, allowing sugar to enter the cells. So insulin lowers the amount of sugar in the bloodstream as the blood sugar level drops, where here the pancreas puts less insulin into the bloodstream. So next, coming to the role of glucose. So what is glucose? Glucose is nothing but a sugar. So it is a main source of energy for each and every cell in the body. It makes up the muscle and other tissues in active. So glucose, where does it comes from? So it comes from two major sources. One, food, what we take, and liver. In liver, it is the glucose is stored in the form of glycogen. So sugar is absorbed into the bloodstream, where it enters the cells with the help of insulin. So when glucose levels are low, such as when you have not eaten, like during the fasting or skipping the food, in some few patients, what happens here is the stored glucose now in the liver breaks down as glycogen into the glucose. So this keeps glucose levels with the typical range. In type 1 diabetes, there is no insulin to get glucose into the cells. Because of this, the glucose or the sugar builds up in the bloodstream. So this can cause a life-threatening complications in type 1 diabetes. That's why they are more prone for ketosis, and mainly their presentation will be very severe in type 1 diabetes. So next, coming to the criteria for the diagnosis of diabetes. So how do you diagnose this diabetes? So first thing, as early we discussed the symptoms of diabetes like polyuria, polyphagia, polydipsia, etc. So along with symptoms of diabetes, we have to take the random blood glucose level. So the random blood glucose level may be around 180 to 200 milligram per deciliter. So next, coming to fasting blood glucose level. So it should be around a range of 110 to 126 milligram per deciliter. So next, coming to 2 hours plasma glucose. So what we say it is postprandial blood glucose level. That is after taking a food, that is any breakfast or something like that. after an oral glucose tolerance test, the sugar value should be around 180 to 200 milligram per deciliter. So next coming to the gold standard test for diagnosis of diabetes. So the gold standard test for the diabetes is HbA1c, that is glycosylated A1c. This is nothing but it gives an average sugar value, that is a previous 3 months average sugar value is now called as HbA1c test. So even though if you're going with a fasting blood sugar test and a glucose tolerance test, that is a postprandial test, we again take this HbA1c level to diagnose diabetes. So the normal A1c level will be below 5.7. So in case of pre-diabetes, it is around 5.7 to 6.4 percentage. And when it is crossing beyond 6.4, we term it as diabetes. So what are the risk factors of diabetes? Number one, genetics, and again, family history of diabetes and polycystic ovarian syndrome. So now recently, this polycystic ovary syndrome, where the females they got an history of irregular menses. In future, this PCOD is almost 5 to 10%. They are leading to type 2 diabetes. So next coming to race, most commonly in African Americans and Asians, white Asians, and at the age group between 40 to 45, but increases in younger adults and children nowadays. The environmental factors and physical inactivity and excess weight gain and obesity is other a major risk factor for diabetes. That is BMI more than 25 kilogram per meter. And coming to history of gestational diabetes mellitus or previously identified as impaired glucose tolerance or impaired fasting glucose. And next, with the history of vascular disease, any cardiovascular diseases or any peripheral vascular diseases. So next, we are going to discuss in brief regarding genetically defined monogenic forms of diabetes. So as early previously in types, as we discussed, like MODY, it is a rare form of diabetes, which is different from both type 1 diabetes and type 2 diabetes. So this is caused by a mutation or change in a single gene. So it is a group of inherited disorders of non-autoimmune diabetes mellitus. So genetically, this monogenic forms of diabetes, they have 5 different variants of MODY. So they are caused by mutations in gene encoding and MODY1, that is caused by gene encoding islet cell transcription factors or glucokinase. So here the main activation is in the glucokinase. So what happens here is it have been identified that and are transmitted as an autosomal dominant disorder. So in this glucokinase gene mutation, what happens is a result of mutations in the glucokinase gene, where it leads to mild to moderate hyperglycemia. So glucokinase is nothing but an enzyme. So what happens here is this glucokinase enzyme facilitates phosphorylation of glucose to glucose 6 phosphorus, where this glucokinase occurs in cells of liver and pancreas. So what is the action? So what acts is it is a sensor and it is recognized when the level of glucose in blood rises, and what it does is it helps to release of insulin from the beta cells to control it. So next coming to the homozygous mutations in glucokinase cause several neonatal diabetes. So this MODY 1, 3, 5 type caused by hepatonuclear transcription factor, that is 1 by HNF4 alpha, and MODY 3 by hepatonuclear transcription factor 1 alpha, and 5 by hepatonuclear transcription factor 1 beta. So they are caused by mainly in the mutations in hepatonuclear transcription factors respectively. So what happens here is about 50 to 90% is the commonly what we see is MODY 3, and around 30 to 50% what we come across is MODY 2. Next, coming to a rare variant cause is MODY 4. It is a very rare variant of mutations in the insulin promotion factor, that is IPF1. So what happens is the transcription factor that regulates the pancreatic development and insulin gene transcription. So again, next coming to neurogenetic differentiation factor, that is nothing but MODY 6. So what happens here is the gene mutation cause, that is it results in beta cell dysfunction with consequent hyperglycemia. So it is monogenic, autosomal, dominant disease. So it is this neuro D1, it is a very rare form of diabetes mellitus. So here what we we don't use also insulin for the treatment, but we use sulfonylurea as first line therapy for the treatment in, especially in this neurogenetic differentiation. So this neuro D1 is expressed mainly in the nervous and pancreatic tissues, and they are necessary for the main beta cell development in the pancreas. So they cause what does it causes, like they cause beta cell dysfunction, inadequate insulin secretion, and hyperglycemia. So next coming to mitochondrial diabetes. So in mitochondrial diabetes, we come across a very poor functioning of insulin producing cells in pancreas and or by insulin resistance as part of mitochondrial diseases. So next, we are coming to genetic defects in insulin action. So what happens is there will be a insulin resistance. It is a very rare disorder and it is characterized by severe insulin resistance. That is type A insulin resistance. Here, mainly the body tissues and organs do not respond properly to the insulin hormone. So next, coming to leprechaunism, this is a very extremely rare disorder. So again here it is characterized of an abnormal insulin resistance. And next coming to this Rapson-Mendelian syndrome, and again it is a very rare disorder, and it is also characterized by severe insulin resistance. So mainly here the genetic defects like the insulin action, where the insulin secretion is also like the main part, there only will be having an insulin resistance. So the body tissues, they does not respond to the proper insulin secretions, that is the insulin hormone. So it gives rise to any abnormal or severe insulin resistance. And next coming to lipodystrophy, or a loss of subcutaneous fat tissue. And this in diabetic mellitus is associated with lipoatrophy. That is, it is an autoimmune disease. So what happens here is there will be a partial or complete loss of an abnormal distribution of an adipose tissue. That is nothing but a fat tissue. So what happens here is there will be a abnormalities of the adipose tissue. So mainly we will be seeing this lipodystrophy of the diabetes in leprechaunism. So next coming to the complications of diabetes. So main in complications of diabetes, it comprises of acute and chronic. So only acute, we come across diabetic ketoacidosis. So this diabetic ketoacidosis is the only acute complication where mostly this type 1 diabetes is diagnosed. What happens here is in DKA, they'll be presenting with pain abdomen, and there will be Kussmaul's breathing and hyperglycemia. And in the other second acute complication is hyperglycemic
Doctor, sorry
hyperosmolar.
to interrupt. The slide is not visible.
No, slide is not 1 second. Sorry. Huh? Slide வரல. Okay.
இது ப்ரெஸ் பண்ணது சின்னது பண்ணல ஸ்மால் சைஸ்
Next. Okay. Is it okay?
Not visible, ma'am. I think slideshow it's not working. Can you share the slides once again? Can you reshare? Now I can see complication for
Yeah.
diabetes.
Yeah.
Okay. Yeah.
Can we start?
Yes, ma'am. Yes, ma'am. We can start. Yeah.
மேலே கீழே பண்ணி போகுது ஸ்லைட் ஷோ வச்சிருக்கோம் ஒரு ஃபர்ஸ்ட் கீழே ஸ்லைட் ஷோ யூஸ் பண்ணுங்க
Don't have to keep it in slideshow mode, because slideshow mode the screen, the slides are not moving.
இப்படி வச்ச காட்டாது உங்களுக்கு அது நமக்கு சின்னது
Yeah, now it's fine,
Sorry.
ma'am. Complication for
Sorry.
diabetes, you can start. Yeah.
So complications of diabetes. So under the complications of diabetes, it's of acute and chronic, and under acute complications, DKA, that is commonly where we diagnose the type 1 diabetes. So in DKA, the patients will be presenting with pain abdomen and Kussmaul's breathing, that is a fruity odor, and acetone breath smell will be present, and hyperglycemia, and mainly due to the immunodeficiency. The next acute complication is hyperglycemic hyperosmolar state. And next coming to chronic complications. So under chronic complications, it is of vascular complication and non-vascular complications. So under non-vascular complications, vascular complications, again it is subdivided into micro and macro complications. And under micropathy, like micro complications like retinopathy, neuropathy, nephropathy. Under macro complications, coronary artery diseases and peripheral artery diseases and cerebral vascular diseases come under this macro. And coming to non-vascular chronic complications, we come across gastroparesis and skin changes will be seen. So how do you prevent this type 1 diabetes? And as such in type 1, it is not preventable as of right now, and many studies on ways at possible to prevent the further destructions of the beta cell. That is, we have to identify the type 1 and before the beta cell is lost. But mostly type 1 presentations will be, the presentation will be to the emergency, that is to the emergency ward with loss of 80 to 90% of beta cells. And here we have to maintain and control the good glycemic levels and with insulin. And with a good healthy lifestyle, It is nothing but a good physical activity. It is a good brisk walking, that is exercise, and a good diet. And there is some research going on with islet transplantation. So coming to preventions in type 2, primarily first we have to give a good education. That is to proper diabetic educator have been implemented, has to be implemented, and with a good lifestyle modification. In good lifestyle modification, nothing but brisk walking. That is around 30 minutes for a 30 minutes. In 30 minutes, they have to cover around 5 kilometers. That is known as brisk walking. That is a good by increasing the physical activity, and by secondarily by checking the A1C levels. That is, it gives the average previous 3 months of sugar levels. And next, tertiary again, exercise and a good food. That is a diet counseling has to be given. And again, in mainly in type 2, every time a food examination has to be done. So each and every day we have to instruct the patients to have a food examination before going to bed. So in case of prevention in gestational diabetes, we have to increase the physical activity, and now the researchers have been found physical activity before and after the pregnancy have reduced the risk of gestational diabetes by about 70% and or more. And again, by taking a 10 gram of fiber a day reduces the risk of GDM by 26%. So how do you monitor this diabetes at home? Like just simply taking a blood sample, a drop of blood sample, and it has to be put on the strip by using a glucometer, and you have to maintain a log book and keeping the blood glucose level to maintain and monitor it. Next, coming to a twin study. In this genotype studies, first we have to make a difference between the identical twins and non-identical twins. In non-identical twins, what happens here is generally they share 50% of their DNA, and usually said that this identical non-identical twins share 100% of this. So what we found here is they believe that the differences are due to the difference in the lifestyle, and this confirms the theory that type 2 diabetes is very strongly linked to the non-identical twins in to the lifestyle. Whereas coming to identical twins, they have a more proof that gene alone is not enough in identical twins and identical genes. Therefore, they should have the same genetic risk for the disease. And the researchers have also found that one identical twin that who has an individual who has type 1 diabetes, the other twin will get the disease about 50% of the time. Meanwhile, within that time, in future, type 2 diabetes, that is, there will be a right risk of to get much as in 4 to 5%. So in both type 1 and type 2, and identical twins have a much higher risk of both developing diabetes than non-identical twins. In future, what they're going to, how they're going to come out of this, prevent this diabetes, that is how to prevent the loss of beta cell destruction. So what they're going to do is they're going to regenerate the human beta cells. So it is, the process is going on. So there will be a in that is both type 1 and type 2 diabetes, a complete or partial loss of beta cells number and a function they are planning to regenerate by the human beta cells. So what happens here is there are differentiated with the cell types and use of a non-human beta cell sources like guinea pig or non-human primate islets, and finally they are expressed on human beta cells from deceased donors. Regardless of the origins, there is a clear need for more beta cells for cell replacement therapy for the diabetes. So next, again coming to, as we discussed, a risk factor, obesity, a brown fat transplant may aid in weight loss in the management of diabetes. That is, we come across the type 2 diabetes, obesity is one of the risk factor. So at least two types of, here there are two types of adipose tissue. That is, one is white adipose tissue and other one is brown adipose tissue. So there are recent studies that is like brown fat transplant has a good weight loss in diabetes management. That is decreasing the weight loss. So next coming to the what are the barriers that is in the gene incorporation. So first we have to identify the genes. That is, animal studies have been studied and the human genome project have been studied, and disequilibrium based approaches and more genome scanning, including a pooling or a subject of a group, have been identified in the genes. And appropriately phenotype samples, that is a rate limiting step, and typing technology is also used. So thank you.
Thank you, ma'am. Indeed,
Any doubts? You can
yes.
hear it.
Yes. I have, got couple of questions, 2-3 questions.
Yeah,
Maybe we
sure.
can discuss now.
Yeah.
The first question is, what is an insulin suppression test? Can you brief?
Yeah. Hello. Insulin.
Suppression test.
Insulin test.
Yes. Insulin suppression test.
Yeah. To identify diabetes, like mainly we use the glucose tolerance test, or this we recommend glycosylated events, that is HbA1c.
Okay, ma'am. The next question is, I think it is related to diabetes and eye care. What are the complications of diabetes and eye care, and how we need to diagnose?
So yeah, the subject, like the patients are recommended to take an early yearly checkup of their fundus. So this, it is a chronic vascular, that is, it comes under the vascular, that is micro complications, retinopathy, like glaucoma, cataract, everything. It is an early in onset in this eye testing.
Thank you, ma'am.
Retinopathy, yeah.
Retinopathy. Okay, noted. And the next question is, how does type 2 diabetes mellitus impact morbidity and mortality?
Yeah, definitely. Because most of them, the presentation is only with complications nowadays. So the main thing, due to lack of physical activity, and the pre-diabetes is mostly hidden. Okay, so the presentation will be coming with us with with vascular complications like coronary or with the cerebral vascular disease, or sometimes even with peripheral vascular diseases. So, and here even with neuropathy. So what happens here is like with so some of the patients have also undergone amputations due to the lower extremities amputations due to the uncontrolled diabetes.
Okay, ma'am. The next question is, what is the first line treatment for gestational diabetes? Can you brief?
Can you repeat it?
What is the first line treatment for gestational diabetes?
First line treatment. So just we're going to do oral glucose tolerance test at the 5th month. So at the 40th, 20th week, we are with the gynecologist, they'll be suggesting the oral glucose tolerance test. That is, we take this, the subject is ask them to come in a fast, like they'll be giving 200 grams of or 100 grams of glucose to the first they'll be taking a random blood sugar at an empty stomach, And again, with giving of 50 grams of glucose, the fasting, the second blood sample will be taken. And again, the third blood sample will be taken. And here, if the fasting blood sample is coming within 100 to 120, we say it as gestational diabetes mellitus. So glucose tolerance test GGT is a gold standard test for GDM.
Thank you, doctor. Doctor, can we take one more question?
Yeah, sure.
Yeah. Doctor, you have mentioned about diabetes and PCOS relation. Does
Yeah.
diabetes make PCOS worse? Can you brief?
Definitely. So nowadays we are getting few paper, we are preparing for few journals like PCODs means that are both thin and obese PCOD we are taking into the subject. This PCODs in future they are in turn going into frank type 2 diabetes in untreated cases.
Okay, ma'am. Thank you.
So definitely they have to go for lifestyle modification, that is increase of physical activity, and main thing they have to decrease their weight. Weight reduction is very important, and until they have to regularize these cycles, menstrual cycles. It is must in PCODs.
Okay, ma'am. Thank you. Doctor, can we wind up today's program? Maybe.
Yes.
Yeah, sure. So, on behalf of MedPiper Technologies, JonaMed, Indian Medical Students Network, Jubilee Unit, and Amala Institute of Medical Science, we would like to thank Dr. Shubha Priya for joining us today in detailing inherited diseases that affect diabetics patients. Thank you so much, Doctor, for spending your day with us and sharing the insights on the latest updates in diabetes as well. And thank you so much. We look forward for more collaborations and work with you, ma'am. Thank you so much.
Sure. Thank you. Thank you so much for giving me this opportunity. Thank you all.
Thank you, ma'am.
Thank you.